within the last few months, we were Children's Foundation of Mid-America, if that means anything to anybody. We're out of the St. Louis area. The agency that we work for is a social service agency. It has a little bit of residential, but mostly it's just kind of a community foster case management kinds of services. Owen and I work in a program called Family Solutions for Kids. It's an in-home intensive counseling program funded by the Children's Trust Fund, or the Children's Service Fund, so, which makes it free to youth and their family members between the ages of 4 and 19 years in St. Louis County. So it really is, I mean, it is quite a remarkable thing. Also through that funding, we were able to attend trauma-focused cognitive behavioral therapy training through the Children's Advocacy Center on the UMSL campus. And they've been able to do that a couple of places. So as you know, actually, I'm a supervisor and Owen is a case therapist. So Owen has the vast experience with this model, so he'll do most of the talking. Well, he's a better presenter anyway, I'll just say that straight up. But I do want to know, if you could raise your hand if you're a counselor or a therapist. Okay, great, okay. If you do in-home work, who does in-home work? Yes, okay, good. Some of what we're going to talk about is going to be applicable to office, but we're really trying to tweak this model to in-home since that's what we do. How many of you know of trauma-focused CBT?
Just in general.
Just in general, okay.
You heard the name and you sort of know it used with kids.
And then how many, yeah, okay, how many of you use it in your practice? Okay, all right.
Let me ask a question real quick.
Please do.
Is it something that is applicable?
Is TF-CBT applicable to adults?
I work in a prison with substance abuse people, and the thing I deal with, and the reason I thought this might be appropriate, is I deal with a lot of guys that have had some really crappy stuff that has happened to them as they were growing up, and they're still struggling through that.
Really good question. TF-CBT is designed and validated and a wonderful evidence-based practice for children and adolescents. It is not gold stamp seal of approval for adults. But a lot of the trauma-based, cognitive and behavioral-based foundations for this are applicable at all ages. And this sort of narrative work we'll talk about later, and sort of some of the components of this are really applicable with adults too. Some of the stuff you won't see that won't be applicable is that this really talks about family and parents as well. I think that a strong support network in terms of dealing with the trauma is a significant one. When you're incarcerated, you really don't have that. So that's a big component of this too. And so some of the factors in here, I think you'll find some tidbits for you, but there's some other stuff that may not apply.
Okay. I was just wondering if there would be set off on somewhere.
You know, and if we get into it, you feel like it's not helpful to you, please. You know, I mean, you know, go someplace where you think, you know, it's more helpful.
Yeah.
What I will say in this intervention, this modality, there, up until the trauma narrative, you can use any of that on any client that you're working with. We'll talk about, Owen will talk a bit more about the crack. It's the psychoed, the parenting, the relaxation.
Good CBT related stuff.
Absolutely. You know, so that will help.
Just as a general feeler out, who has a strong understanding of trauma, just trauma in general, impact of trauma? Cool. Who has a strong understanding of cognitive behavioral related stuff? Cool. Who has a strong understanding of doing in-home stuff? Cool. So we've got, there will be something for all of you here. And if you want more or less of something, feel free to kind of speak out. And if we're getting off track, I'll just let you all know. Does that sound okay?
Or y'all let us know.
Yeah. So just kind of in general, we've got sort of 3 major goals. And Beth's going to kind of start off talking to us more about things, and then we'll go from here. Why don't you pick up and move from here?
Right. Okay. And we're just going to like flip through this. We hope for those that don't have an idea of what trauma-focused CBT is, that you'll leave the room today with a better understanding. We also hope that you will be able, for those of you that are doing the in-home work, that you'll be able to tweak this model for the in-home work that you're providing. And then we're going to talk about some of the benefits that, as we see them, and some of the obstacles as we see it providing this as an in-home service. Just like the general definition.
Yep.
Oh, I'm sorry, I don't know.
No worries.
I think we pretty much can all agree, just very general, probably most, if not all of us in this room have experienced or witnessed a traumatic event in our life. Most of us do not go on to develop PTSD symptoms. And there are a number of reasons for that. I mean, it could be the age of the exposure, it could be, the source of the exposure, individual temperaments, the family support, social system support that we get, exposure to previous trauma predisposes one to subsequent trauma or developing PTSD symptoms. So many of us are really quite resilient to this. The other huge concern that I have, we can go to the next one, is that I think that PTSD is underdiagnosed or misdiagnosed. And we work primarily with children, so that's where we're coming from. I'm sure it goes to adults too, but the PTSD symptomology can look very much like ADHD, can look very much like oppositional defiant disorder, I think, and bipolar, anxiety. So I think it's crucial for us to be very careful about our assessments, our history taken, and then the assessments that we use. Because what we're talking about here is hugely important to me, is we're talking about a kiddo that probably has been labeled as a bad kid or a defiant kid, and really this is a kid that's been traumatized a lot of times. And we've got kids out there that are being prescribed medications like tropomeds that probably aren't doing a blip for really what's going on. I mean, there is some comorbidity, but that's not what I'm talking about. I'm just talking about misdiagnosed kiddos. Assessment. Right. What we use, and I think there's a clip of one, there are two, what I would call, this is a trauma screener that we have kind of tweaked along the way. And really what it's looking for are incidents of trauma in a lifetime. So at intake, when we're, initially meeting with a child or family, we're asking these questions. We're looking if any of these things have ever happened. We use this in the the UCLA PTSD index as just trauma incident scales or screens.
These are things that oftentimes when people are doing assessments, either grown-ups, kids, anywhere, you're asking someone, has anything ever happened to you?
Right.
You're not necessarily going through and asking, oh yeah, of course I was in a house fire. But they're not necessarily going to identify that as traumatizing. And using some of these, especially the UCLA PTSD index, has like a step-by-step question about, has this happened to you? Has this happened to you? Has this happened to you? And it is really helpful for identifying trauma.
Right. And then the other assessments that we use pre and post are this trauma symptom checklist for children or the trauma symptom checklist for young children. And that's a John Briere scale. And that is looking more for just identifying PTSD-related symptoms, like maybe some dissociation, some heightened agitation, depression. I mean, so it's a variety of different things that we're looking into.
I think it does a really good job of breaking down symptoms, and that's really helpful in treatment planning too, when it comes to identify types of PTSD symptoms. Because PTSD can look a really wide variety of ways. I guess since just big picture, trauma is really important, and this is something we miss when we're working with other kids. Let me just tell you a little bit more just about TF-CBT, because I want you to know what the heck is this thing. Most of you said you've heard of this, right? Some of you say I sort of use this. So just in general, I want you to know that TF-CBT is a conjoint child and family trauma-oriented intervention used for children, adolescents who have had difficulty managing symptoms of post-traumatic stress. That doesn't necessarily mean they have to have a PTSD diagnosis, but we don't use this with people that haven't had traumatic incidents, just as a heads up. Also just know that everybody loves this. You're going to be hearing about it a lot because it's a strong evidence-based practice. There's been a lot of studies to really make sure that this is valid, that if we do this in structured, formatted ways that match what other people are doing, we're going to be effective, just period. It's going to be pretty helpful. But unlike a lot of other evidence-based practices, it's not as formulaic as I think that sometimes that sounds, if that makes sense. This is not super rigid. It's pretty flexible too, so don't get scared by that. Please do know that it's been validated to be used with kids of a wide variety of ages, genders, races, cultural backgrounds. It's been used outside the United States and Canada with different languages. It's been used in Africa and in Asia, in Europe. It's been validated and has this sort of evidence-based gold seal of approval for lots of stuff, like lots of cognitive behavioral related stuff. But I'd say that there's some stuff here that makes it more than just coping skill boilerplate stuff too. So I want to give you just a little bit more background here. Who do we use this with? Kids of a wide variety of ages. And there's some things that could rule out use of TF-CBT, but not necessarily. Things like, the biggest ones for me that when I look at this are just ongoing safety and victimization issues. Also, when you mentioned talking about incarcerated individuals, in unsafe environments, you don't necessarily want to do trauma work with someone when they're going to be more sensitive to vulnerability, and then do more trauma work when they're going to be having ongoing victimization. But I want to talk a little bit more about that later too, because there's a lot of flexibility for that too. And there's a lot of gray zones in terms of how somebody has difficulty managing symptoms of trauma when there's just life situations that are tough, just for extended periods of time. I also want to point out that substance abuse issues are a big one when dealing with trauma. When people are emotionally blunting themselves with substances, it's hard to have them learn individualized natural coping mechanisms and reframe their thinking about trauma when they're using substance abuse as an out. And so that's one of the ones that I think is probably the biggest rule out for us.
That's the biggest. I think it is possible to an extent if there's a co-current. I mean, if that individual's involved in a drug substance abuse treatment at the same time we're doing, I think it's possible.
Yeah, totally think it's possible.
Yeah.
But with someone with an active substance abuse, that's one of the biggest rule outs, if that makes any sense. I would also say that at the bottom here, it's ideally designed to be done with a caregiver of a child or some sort of natural support system. I want to talk more about that later as we go too. You all raised your hand when you said, oh yes, I know trauma, yes, I know cognitive behavioral stuff. So you know the theoretical foundations here. But I want to also point out that meaning making and what trauma means. Oftentimes when we do cognitive behavioral stuff, we think about how you think, how you feel, how your body reacts, stuff like that. But we don't necessarily think about the underlying beliefs. When we talk about antecedent behavior consequence when it comes to cognitive behavior related stuff, the surface level stuff is coping skills. But we really want to spend a lot of time talking about meaning making and purpose, the purpose of the sort of traumatic work that we're doing too. That stuff is a big part of TF-CBT, and what I would say really makes the sort of long-lasting impact instead of just symptom management, if that makes sense. So this sort of meaning-making component here, I think, is how do you identify the issues that are really underlying beliefs that are causing you difficulty about the trauma you've experienced, and how do you change those to be more functional, helpful, and supportive sort of absolute meanings. That's something I want to talk more about as we go on too. Just in terms of layman's terms, if I were to describe this to a family, I would use some of these metaphors. And you all know some of these metaphors too. You've got to clean out a wound so it can heal. You have to make sure that you can fill your toolbox. How many of us have ever said the word toolbox to a kid? Right. I know that these are the things that we keep sense. In terms of meaning making, I know that I want to plant some important thoughts and ideas for these kids and for their families so that they don't have a garden overrun with weeds or distortions all about their trauma. This will make a lot more sense. And if you have any questions about that, just sort of describing this to other people, let me know later. When it comes to the actual nitty-gritty of TF-CBT, these are the modules. That's the fancy word for it. These are the steps you're going to take when you're working with a family. The nice part is that each one of them is fairly clear-cut. There's specific work you're doing with a family or an individual at any given time, starting with education, relaxation, all of these things, just reading as we go. In terms of...
Slow down just 1 minute.
Quite right.
It's the prac piece that I think is applicable to most any client that we work with.
I think that this slide kind of breaks down sort of the overview of kind of, I'll flip back to the other one so you can know what all these little letters stand for. But practice is sort of the easy to remember, hopefully easy to remember, sort of framework they set up for the steps of this sort of thing. There's skill building situations at the beginning. They really want to, with TF-CBT, we want, before we start exposing kids or adults or anybody to the actual traumatic experiences they've had. How many people have you said, oh, you need to talk about it, stuff like that. Talking about it is hard. It can oftentimes re-traumatize you, and it can oftentimes make you more vulnerable before you have the skills to actually cope with any of it. First, we really want to work with kids and families to increase their skill building. And that means I really want to work on psychoeducation, P-R-A-C. Psychoeducation, I want them to have an understanding this is not just a bad kid, a troublesome adult. I don't want them to think this kid's a punk. Why is this kid doing this? This hasn't affected their brother that way. This doesn't affect me this way. We need them to understand psychoeducation.
Yeah, and this is very specifically where we're talking about what a rape, okay? I mean, the statistics on a rape, or the statistics on domestic violence, and what are symptoms of, or that come out of situations like that. So that's the psychoed piece.
Then I really want people to understand the RAC. These are sort of your cognitive triangle related stuff. I want them to have increased coping skills to manage traumatic reminders, to manage troublesome activities and behaviors that they're having at home or at school. If they're thinking about the house fire they're in, if they're thinking about the traumatic death that because of some reminder, because we're having oatmeal today, or meatloaf, oh shucks, dad made meatloaf a lot. I want these kids and their families to be able to manage the sort of traumatic reminders and the everyday difficulties that they're dealing with already. And that sort of skill building sort of area is really significant. And also, most of you probably do this with kids already if you're doing CBT stuff. You probably do this with adults already. This is when you ask them to manage their body, manage their feelings, identify their feelings, identify what they're thinking. These are things we do already. The next stuff, the trauma processing, is a pretty big one.
Hold on, just one minute. Are there any questions about that or any comments about that piece? Does it make sense? Okay.
After families and kids have greater skills to actually manage their own symptoms, essentially, and this is the part that most people get to when it comes to therapy stuff, managing symptoms. The next part is actual trauma processing. And this is where you get past just sort of cognitive behavioral stuff and into really trauma-informed practice, even though it goes throughout the entirety of this process. Developing usually some sort of trauma narrative, some sort of story with a kid for the actual experiences they've been through is a big part of walking them through not just traumatic memories or education about all rapes in general, or all sexual abuse in general, or all domestic violence in general, or all house fires in general, but actually walking them through their rape, their sexual abuse, their house fire. These are the things that honestly that they're going to be harder for an individual to manage. I don't really want them to start managing their own memories without having some skills. But I also want them to gradually be desensitized to the extreme reactions they were having beforehand. So gradual desensitization is a big part of the trauma narrative, first off. I want them to simply have a less explosive reaction, or a less withdrawing reaction, a less dissociative reaction at some point to all of these memories and experiences they've had.
So that's not a one-shot session.
No.
I mean, this trauma narrative is developed over time, over several weeks.
And I would say that a big part of that, beyond just desensitizing to individuals, I want them to be able to talk about it without blowing up. Also, I want to go through this process in order to identify beliefs and ideas. I want to figure out, what did having a house fire, a rape, a sexual abuse, domestic violence mean to you? So what were you thinking when that happened? What does that mean? Asking those sort of questions really gets me to the point of, my parents got in a lot of fights because I didn't do my chores all the time. Our house fire happened because I left the stove on. And maybe it did, maybe it didn't. But regardless, I want to figure out what it meant to this kid that this traumatic event happened. I was sexually abused, and so I'm broken now. Nobody wants to spend time with a hurt kid. These are sometimes true, sometimes false, but regardless, the underlying beliefs that are kind of prompting a lot of these behaviors and frame how these children in these families think about trauma. And I wanted to identify anything that's a not helpful, not true, not functional idea. Anything that is not true is simply not going to be helpful. And sometimes, yes, maybe you did not watch your brother and he fell into the pool and drowned. And yes, that's true, but thinking I'm an awful brother and my family's never going to forgive me is not going to be functional or helpful to really get you through the rest of your life with your family. I want to be able to identify those and help kids through this process of going through their story in order to just change it, reframe those beliefs, challenge them about untrue beliefs, help them reframe so they can have more functional, helpful, true understandings of what happened and how to go about it from there. And I would say that that's functional and helpful for everybody when it comes to trauma. They need to have accurate and they need to have helpful sort of underlying beliefs about the trauma that happened to them. And then we spend a lot of time at the end having conjoined sessions.
Did you say they need to have a healthier?
Helpful.
Yeah, helpful. The things that are oftentimes most important about the underlying beliefs, what you think about traumatic things that happen to you, is it true? Is it really true that the house fire started because I left my fire? Or did I get raped because I spent too much time around with Uncle Joan? These things happen. Is it true? Second, is it helpful? So is it really helpful to think, I could have done something about this and have that just rack you with grief the whole time? And because it may or may not be. And finding helpful and accurate, those are both very important. Really true and helpful underlying beliefs are the most important factors to helpful there. Yes?
What if you have no way of knowing whether it's true or not?
Good question. And I want to address that a little bit, because that sometimes, especially with young kids, you're not going to know. Or other times with traumatic events, you're not going to know exactly what happened. And I would say that the gray area of I don't know what the trauma actually is a tough one, because you can't necessarily ask someone to tell their story if you're reinforcing inaccurate information or just false stories. So this is something that I would say that we tend to work with kids and families that have verifiable, or at least generally verifiable traumatic incidents. And I would say that this doesn't need to mean that we have every detail. This does mean to know that it's been verified, that we know in general at least what happened. And I would say that I want to know, especially if there's any interpersonal violence, I want to make sure that I know as much as accurately as possible who's involved, stuff like that. That way, when I'm working with a kid and they're doing a trauma narrative and they mention Bob, I'm not totally thrown about who Bob is. Because Bob could be some sort of dissociative fantasy figure. Or Bob could be a real life person that my aunt brought over who had then sexually abused me. So there's having a verifiable story is kind of an important part of that. Thanks.
Even if it's not helpful or functional, you can always move to those two categories.
I know that if I can't verify if it's accurate though, that's kind of a difficult situation. Because if a kid all of a sudden tells me about a situation where I don't know if it's true, or I'm working with a child that has sort of dissociative fantasy symptoms, so they just retreat into a fantasy world. This happens not uncommonly with smaller kids dealing with fantasy, dealing with trying to cope with trauma. If they are telling me fantastic things and I can't identify what's true or what's not, there's no way for me to get to the underlying belief about what they're talking to me about. And so I at least need to know a general picture. But then I can start figuring out what is accurate and what isn't. And I can kind of leave the other stuff as long as I get to the bulk of it. Does that make any sense? Is that helpful to think about? I see nodding heads. That's good for me. This last bit is a big important one too, because I don't want to just think that, oh, we've talked about trauma, we're all set now. There's two things that I think that really need to happen afterwards, and this is what TF-CBT says. We need to have conjoint sessions. This is the C down here. I want to talk back up real quick. In vivo stuff. There's plenty of kids that have just difficulty with real life trauma reminders. I worked with a young kid who was sexually abused by a neighbor in his basement. And he just stopped going to his basement.